I want to invite Dr. Thomas Santarius and Tarek Rayan to moderate a session of Dr. Ed Benzel for tricks from masters. I think Tarek Rayan is with us. Tarek?
Dr. Zalili,
Yeah. Unfortunately, my internet connection is not good. But Tarek Rayan, you can moderate the session.
absolutely.
First, introduce Dr. Ed Benzel, and then start the session.
Yes. Good evening, everyone. It's quite not so late here in Abu Dhabi. I would like to introduce Dr. Benzel, Edward C. Benzel. Benzel, our prominent speaker tonight for this webinar. Dr. Edward C. Benzel is a distinguished neurosurgeon, the chairman of the Department of Neurosurgery at Cleveland Clinic and professor of surgery at Cleveland Clinic, Lerner College of Medicine, and Case Western Reserve University. So with no further ado, please, Dr. Benzel, would you like to start your presentation with us?
Hello, can you see my screen?
Yes, I do.
Okay, well, I'm going to begin with about a half hour to a 45-minute talk. I am going to go back and forth from lessons learned and teaching points to discussions of biomechanics, etc. So I'm trying to weave the talks in a way that I believe Dr. Zalali asked me to. Come on.
Can you make it a whole screen, please? Yeah, good. Thank you.
So my talk is Tricks of the Trade, and I'm going to call it My Journey. I'm assuming, and correct me if I'm wrong, that a large number of young neurosurgeons, including residents, are on this webinar. Is that correct?
Yes.
Okay.
Yes.
So I'm talking about my journey, and then what some suggestions of what your journey, the young neurosurgeons, might look like. I have 4 things listed here that were very impactful to me during my career. I was sort of a lost soul after medical school, and I ended up in a general surgery internship. And in December of 1975, I rotated on neurosurgery. And I was swept away. They offered me a job as a resident, and the rest is history. So my journey specifically began in December of 1975. Another seminal point in my career was during my first job at LSU Medical Center in Shreveport, Louisiana. This medical center did not have a neurosurgical residency. And I was the only neurosurgeon in a very busy trauma center for multiple years. And I established a clinical research team and a laboratory looking at ECIC bypass surgeries, etc., and published a lot of papers. And one of the basic scientists at the university said to me, and keep in mind, I was green, very young at this point, with little political experience. He said, I would like you to invite John Jane, a icon in the day of neurosurgery, to be our visiting professor. And I said, this is a daunting task, but I did. And he was evidently impressed and invited me to my first visiting professorship at the University of Virginia. Biomechanics has sort of become my trademark. And in the early 90s, my first spine fellow encouraged me to write a book because I had a lot of work that was just sitting around. And so I did. And I published this first Biomechanics of Stabilization edition, followed by 2 other editions. The second one had 32 chapters, and the last one had 40 chapters. And this has defined who I am from a clinical perspective. And more recently, Max Bowacki from Louisville in the United States crafted a question and answer book, which is listed, which is shown below, to answer questions regarding each chapter. Then I was encouraged by Micah Puzzo to make a volume for spine surgery like he did for brain surgery, techniques, complications, and avoidance and management. And I did. And now we're working on the 6th edition of this. Here you see the 5th edition. And in that, we discussed fundamental physics. Bending moment equals force times distance. A load F, or a force F applied at a distance d from an axis of rotation, causes a bending moment, which is the product of the force times the distance. This causes a concentration of stresses ventrally, which results in an angular fracture, in this case, a kyphotic fracture. Now, if that load is placed in line with the axis of rotation, we do not see a bending, nor do we see a concentration of stresses. Henceforth, it takes much more of a load to cause an injury. And of course, we can see other eccentric angles for fractures. And in this case, which is a chance fracture, the fulcrum or axis of rotation is in front of the spine in a seat belt without shoulder harness, deceleration injury in a motor vehicle accident. I said the last thing that is seminal here is the word pillars. Each of us who has met with success has probably had somebody else, perhaps in the background, that functions as their pillar. And this is mine, my spousal unit or wife of 47 years married. She has been an incredible support. So my recommendations to all of the young neurosurgeons who aspire to become an academician, get one of these. If you have one of these, a spousal unit, and she or he is a good one, then do whatever you can to keep her or him. And if you don't have one, find one. So this is my journey. I started off at Washington State University in 1967 after graduating from high school. And it's a small university in the state of Washington. And I got a degree in chemical engineering, but I found out soon that I really didn't like engineering, and I applied to medical school and was accepted at the Medical College of Wisconsin. in 1971. And I did my neurosurgery residency in 75 to 80. In those days, I think my class was the last of the 5-year residency. Then it went to 6, and then, of course, up to 7 in the United States. My first job was at Louisiana State University from 81 to 89. Did a lot of clinical care and research, as I've alluded to, and had John Jane as a visiting professor, which was another, as I already mentioned, seminal moment in my career. I then went in 89 for 10 years to the University of New Mexico. I had conflicts with a chairman of surgery. I was a division of surgery, so be careful of who your bosses are. But one thing I learned from conflicts is to always treat people the same. Everybody puts their pants on one leg at a time. If you're working with orthopedic surgeons or neurosurgeons, don't ever think you're better or lesser, because you need to maintain this egalitarian attitude. While at New Mexico, we started the American Association of Neurological Surgeons Spine's hands-on course. It was a week-long course, began in 1994 and continues today as the Cleveland Spine Review. It's over 30 years of continuous provision of education. I started a neurosurgery residency at the University of New Mexico, and I had some notable characters such as Mehmet Zalali and Dan Resnick, amongst others, who did observerships or rotations with me. They energized me, and I hope they got something out of their experience in New Mexico. I started a spine fellowship. I mentioned the first spine fellow recommended that I write a book, and I did, and also many manuscripts. Then I moved to Cleveland in 99 at the Cleveland Clinic. I became the program director and then the chairman, and now I'm an emeritus chairman and retired, I might add. I retired from clinical care, but still maintain my academic work, etc., at the Cleveland Clinic. I played a seminal role in the creation of the Center for Spine Health, which is a multi-dimensional, multi-specialty group, including orthopedic and neurosurgeons and physiatrists and pain management doctors. And each of us work in collaboration with the other and provide, I think, a much better service. There are obstacles. If you tangle with somebody, make sure it's somebody who you have rank over if you can, because rank usually wins. So I moved 3 times, which is what an average academic neurosurgeon does in the United States. But the last 2 moves were because I was up against people who had control over me, and in my opinion, did not have my best interests in mind. Take homes: focus on education. Don't give up. Follow your dreams. Resolve conflicts and be egalitarian, and strive to do the right thing. If you do those things, you will usually prevail. Now we're talking about your journey, not mine, but yours, whoever is listening here, I guess, to even the older neurosurgeons, but also in particular, the younger neurosurgeons. I define leadership, and you will see that leadership is an extremely important component of what I think is needed to become successful. The art of leadership is the art of causing others to deliberately create a result that otherwise would not have happened. If you go to the internet, you see all sorts of categorizations of leadership. Most of them are based on reward and punishment, except the last 2 here. Thought leaders are individuals who are recognized as an authority in a specialized field and whose expertise is sought and often rewarded. You want to be thought of as an expert, as a thought leader, as somebody who makes a difference. And then there's the servant leader, which I'm really pointing out to emphasize that this is a servant leader exists at multiple levels. Each of us are servant leaders because each of us are leaders. The servant leader serves the people he or she leads, which implies that those who are led are an end in and of themselves rather than a means to an institutional purpose or bottom line. Servant leaders lead people to a better place. The art of causing others to deliberately create a result that otherwise would not have happened. Theodore Roosevelt, a long past president of the United States, once said, "People ask the difference between a leader and a boss. The leader leads and the boss drives." And this cartoon, I think, depicts this very well. You want to be a leader, somebody who people want to follow. And as this chap up front here pulling the barge or whatever. Now, being a chairman of a department or some equivalent position requires this foundational servant leadership requirement, colleagues and healers effective and become an effective communicator. But they also need other skills, managerial skills, operational skills, and those three types of leadership basically, and including thought leadership, basically are what is necessary to lead a department, but not necessarily just leading people. Neurosurgery residents should lead each other. They should lead patients to make healthier choices. They should be functioning as a team and communicate effectively. For those of us who do not communicate effectively, and that's practically all of us, at least at some certain time, this book, Crucial Conversations, is a very good book that discusses how conversations can go bad and how they can go right and how you can make a conversation a win-win situation. Sometimes we get into conflict with another individual. And it's not because we don't care. Everybody wants to care. Everybody wants to have good relationships. But sometimes they go awry. What empathy is essentially is that it's the expression of the fact that you care. So constantly be thinking of caring, but also showing it, show others that you do care about them, about the topic at hand, etc. Leaders are competent. When we're interns or maybe medical students, we don't know much, and we don't know that we don't know much. So that's unconscious incompetence. When we become a first or second year resident, we become conscious of the fact that we're incompetent. And it's a very unnerving time for us. Then as we meander through the residency, we become consciously competent. We're always working at it, but by and large doing a very good job. And then we get complacent, take things for granted, and become unconsciously competent. But things can slip through the grates under this circumstance. So one of the things that we need to do is to reflect and have reflective competence. Leaders perpetually reflect. Here I will bring up a term heuristic, which is a rule of thumb. Before you conclude that these are two rules of thumbs. Before you conclude that a treatment was effective, look for other explanations. And if you see evidence of success, look for evidence of failure. Let's look at the first one. This is a large L4-5 herniated disc. And I could take this out and I'd get credit for a surgical save, if you will. The trouble is, for one reason or another, this patient's surgery was delayed and he got better. And we got another scan and showed that the disc was gone. Had I operated earlier, I would be taking credit for it, but that may or may not be appropriate. If you see evidence of success, look for evidence of failure. This lady had progressive myelopathy, did an operation, decompression, and a fusion. Looks pretty good. But let's look at her pre-op flexion extension x-rays and compare her extension x-ray with the sagittal alignment of the fusion. She had chronic neck pain because I put her in a position, an unnatural position of a straightened spine rather than a lordotic spine. And I keep bringing this case up over and over because it, to me, was an incredible lesson. So I'm just going to take us on a quick tour through my journey regarding cervical spondylosis, which is basically clinically manifest by myelopathy and deformity and radiculopathy. The myelopathy is a result of encroachment and tethering and repetitive trauma. Patients often will have a flexed forward spine and in the neck with an extension in the low back, which means they often have low back pain. And they also have the kyphosis trapezius sign. The trapezius muscle is a muscle of accessory muscle of extension, cervical extension, and it's not really very effective. So if the patient can't extend their neck, then this muscle is often activated and becomes painful. This lady had an occiput to thoracic fusion for reasons that were not clear to me. It was done elsewhere. And here she is. Look, she's got the kyphosis trapezius sign. She's got an extended back, so she's got back pain. Look how far dorsal her plumb line drops from the L5, L4, 5 level. Here's another lady who had a compression and flexion fracture, osteoporotic fracture. And you can see how she's standing, got a sore back and significant kyphosis trapezius sign. So when operating on the cervical spine, focus on deformity. Why? You can diminish neck pain, improve myelopathy, decrease infusion degenerative changes, and improve short-term and long-term success. It is very difficult to correct deformities from a dorsal position, and I'll go over that. And oftentimes we need to correct from a ventral location at least, but it's all about leverage. We can use cast bar pins as a stands-like screw to correct the deformity. We can bring the bone to the implant by a 3-point bending strategy. We can see here a kyphosis is converted to a lordosis by simply engaging an intermediate pointed fixation and moving it dorsally, as depicted here. We can use gravity. Viscoelasticity is the gradual deformation of a body with as a result of the application of a constant load. So this lady had multiple operations, had progressive cervical myelopathy and a lot of neck pain. She's got a fusion here and other joints are open. And she's got these signal changes in her spinal cord, but note, this patient was taken care of by me in the very early 2000s. And so I didn't have a full appreciation of this, but the bottom line is she has a signal change in her spinal cord in an area where there is both ventral and dorsal CSF densities. Well, we knew we could correct her ventrally because the facets weren't ankylosed. And we used a donut under her head, rolls under the shoulder, did some decompressions, then took the donut out and allowed her head to extend. You've got to be patient with this because viscoelasticity takes time to manifest itself, and ended up converting a 15-degree kyphosis to a 5-degree lordosis. It's all about leverage. But in the prone position, you have to focus on the head holder. And this, I quit too early. I wasn't persistent enough at trying to make sure that the deformity was corrected. The fixation follows as depicted. One could use a ventral and dorsal approach, but with this ventral approach, I lose the inability to use an intermediate point of fixation to bring the spine to the implant. And it requires two operations to operate a ventral approach and a dorsal approach. Again, this strategy is incredibly important for correcting cervical deformities. Lo and behold, her signal change disappeared. And here she is, pre-op on the left and post-op on the right. And so, in year 2000, I scratch my head and say, now we know, obviously, what's going on, but I didn't then. Here's another gentleman he's about 70 years old, who about 10 years prior had a laminectomy, and he got better, and now he's getting worse again, and this is his MRI scan. Remember that cervical spondylotic myelopathy is a manifestation of repetitive trauma and tethering and distraction. So this is him in extension on the left, and on the right, in flexion. This is what he looks like in flexion on an MRI scan. Significant stenosis, and basically these last two particular cases caused me to get flexion extension MRIs, which we now call dynamic MRIs. And we went through a rigorous process with our x-ray techs so that they would be well versed in dealing with this. And end the riff. If somebody has a myelopathy and you ask them to flex their spine, and by putting a pillow under their head, you could cause the myelopathy or the spinal cord compression to be worsened. And if the patient is in the scanner for a half hour, it could have very negative effects. So the technicians have to be very adept. We knew we could correct this because he moved at every level. His facet joints were jammed. They couldn't open completely. And so we did facet osteotomies as depicted here and corrected his deformity. And he did a lot better. But notice at C23, he is starting to bend forward. He's probably had too much stress placed on this, but we're going to learn in a bit that this angle, the C23 disc angle, is very important for minimizing complications. And today I would have zero hesitancy in going to the C2 because you lose so little movement, but you stabilize the spine so much better. Here's the C23 angle. He was repaired by his neurosurgeon in Puerto Rico, and even though he doesn't have great alignment, his symptoms abated. This is a 38-year-old male with a traumatic C7T1 disc herniation who underwent this operation at an outside hospital. And because he had symptoms, had the implant removed, and here he is. He was fused in this position. And so he's got back pain because he's trying to look forward and extending his low back. He's got the kyphosis trapezius sign. So we took him apart by doing multiple level facet osteotomies, and then multiple level, we used fibula allograft here, but you could use other spacers as well to bring the bone to the implant. So here he is now with the kyphosis trapezius sign gone. The C2-3 angle is important, and we did a study on this. When it's slanting down like this, there's a greater reoperation rate, a greater pseudoarthrosis rate, more chance for progressive kyphosis, and adjacent segment degeneration and disease. Also of importance is the C7T1 slope. It basically suggests problems in the upper thoracic spine that contribute to an overall sagittal vertical axis malalignment. You can see the patient has basically a cervical lordosis, or at least a straightened spine, but his head is way ahead of his upper thoracic spine. We use a C2-3 angle for intraoperative utility. This is a patient who has a lot of axial neck pain and myelopathy. We knew we were really going to have trouble changing the angles of these upper cervical or mid-cervical screws. So we did a C7, T1, T1, T2, T2, T3 facetectomies, and corrected the deformity down below, and then ended up looking like this intraoperatively. And we said, well, if we take that left x-ray, which is an intraoperative x-ray, and we flip it 90 degrees, this is what it's going to look like. And it looks pretty much like the C2-3 angle is horizontal to the floor, as depicted in this middle illustration and the one on the right, if the patient were to be standing. So if I'm going to show this one more case here because I think it's important. It's a 34-year-old male, so he's young and mobile, and he's got a small fiber neuropathy, which has contributed to a spinal deformity that you see here. He is absolutely miserable. He's got a mild radiculopathy because of some degenerative changes. And here's what he looks like in his scoliosis x-ray. And you may note that I get a lot of scoliosis full-length x-rays in order to fully assess the spine, because taking just the cervical spine alone is in isolation can lead to unexpected and untoward consequences lower in the spine. So we did a C4 and upper C5 laminectomy to decompress, a C4-5 bilateral foraminotomies, and a C2-5 instrumented fusion. Multiple partners told me you're not going to be able to get this corrected without going farther down into past the cervical thoracic junction. And I said, there's one thing that's different about this particular patient and the rest of the population that we operated on, and that is that he is young. His spine is mobile. So I put in the screws and then contoured the rods and basically pushed down in the middle as I locked the screws to the rods, and was able to have a shorter segment cervical sagittal alignment and a retained lordosis, as you can see here. Here he is pre-op and here he is post-op. And you can see that if he had scoliosis, the scoliosis views helped a lot. And as his spine is realigned, his plumb line changes. This is because he's not within the picture on the left, which is pre-op, he's leaning backwards to see forwards. Okay. Now he no longer does that. So this plumb line moves forward because he doesn't have to lean backwards. Well, if you look at the literature, it is abundant regarding the suggestion that abnormal angles at disc interspaces causes accelerated degenerative changes. And so we use the C2-3 angle intraoperatively to tell us when it was time to stop. But equally important is if not more important because of the volume of patients, is the short segment fusion that we do like with an ACDF. We should never settle for having a patient left with a kyphotic deformity like this, because they almost assuredly will stress adjacent segments out and have adjacent segment disease. If we maintain lordosis, the chance of that happening is small. So I beg of you to look past the images, look at the human being in whom the spine exists with its pathologies, understand the patient's feelings and expectations, and make sure they're aligned with yours. You don't want them to be the patient to be thinking cure and you saying, maybe not. They need to be completely in line with you. We all need to be socially aware. In other words, be empathic. We all need to have goals, or a vision and goals. We need to have self-direction. We need to be able to make decisions and problem solve. We need to motivate the patient, colleagues, and others to function as a unit. And we need to be self-aware. And I already listed with the competence discussion that the ultimate form of competence is reflective competence. We must always reflect. How am I coming across? What is the patient telling me? And listening is probably an art that is underutilized in modern medicine. And listen reflectively. So, leaders inspire. This was my leader, my chairman of neurosurgery, Sanford Larson. He didn't write this line, and I don't know where I got it, but it describes him perfectly. He was basically a lousy lecturer, but he led by example. People wanted to be, his residents wanted to be like him and do the right thing. And that is what I'm asking of you all. We are all leaders. We get patients to better places. We cause them to take their medications and do exercises and diet if we can. We work with colleagues, friends, and family to build something together, to solve a problem together, to respect each other, to trust each other, and to have mutual respect for each other. So my message to you, and myself, every single one of us, is to lead. Because at the end of the day, if you have been successful in these things, when you go home, you're going to feel like clicking your heels. I thank you very much. I'm having trouble getting back to my regular screen. Well, I know what I need to do. Stop share. Okay, here we go.
Dr. Tarek, you are the moderator, and then ask the discussers to provide questions and a discussion. Ignatius is here.
Dr. Tarek, you have a problem with the voice or the audio? Like we cannot hear you.
Can you hear me?
We can hear you for sure.
Yes.
Okay.
So I'd like to introduce Dr. Heba Azooz and Dr. Esene, the discussers, to open, the floor for questions for Dr. Benzel. Thank you.
Well, I can start. Thank you, Tarek. Thank you, Professor Zilili, for inviting us to discuss. After listening to the incredible story as a neurosurgeon of Professor Benzel, who we know is one of the leading neurospine surgeon globally. When I listened to his story, which began around 1975, it's quite getting to more than 40 years. It's really an interesting life story. I have a few things which I wanted to ask Professor Benzel. I'll start with my own question. We've seen him presenting his work as a surgeon, as a clinician. We've seen him being as a very good educator and a trainer. We've seen him as a researcher who has published so many books and research articles. I think I've had to work with him while he is the editor-in-chief of the World Neurosurgeon. I just want to ask Professor Benzel, I mean, how do you create time to do all these things, especially like with the Journal of World Neurosurgery, where we get a very high volume of articles, yet you're able to find time to treat your patients, find time to teach and train young neurosurgeons?
Well, after doing this for a half a century, it's one thing to say 40 or 50 years, but it has been 50 years since I started on a neurosurgical journey. And that's a half a century. It sort of blows me away. But having said that, at every step along the way was a tremendous amount of work. And I already talked about the importance of pillars, spousal units, my wife, Mary. We had 4 kids, and they all turned out very well. And I was an honored guest for the Congress of Neurological Surgeons 4 or 5, 6 years ago, and Greg Toast and Mike Steinmetz and others said, we want to have a session where we interview my family, not me, but my family. And my next to the oldest, when asked about his relationship with me, and I am his stepfather. The older 2 are my wife's from a prior marriage. He said he was gone a lot, but when we needed him, he was always there. And basically, if you call what I've done as successful, and I'd like to think that it is, it's because I had others pulling for me. And this is a team at home, just like teams at work. But I slept very little. I averaged 2, 3, 4 hours a night for years and years and years, writing and working at night, doing emergencies at night. As I mentioned, when I was at LSU in Louisiana State University in Shreveport, I was the only neurosurgeon for a long stretch of time there. And so I was frequently called in. Having said that, I just did it. And am I sorry I did it? I guess I wish I would have taken some more breathers. Vacations are important. But in the end, I have touched many people, and many people have touched me. And I think I and my family are better for it. Did I answer your question, Ignatius?
Yeah, thank you so much, Professor Benzel. I mean, just to go to my next question before maybe Heba takes on up. I mean,
yeah, I would love. Thank you for the presentation, Professor Benzel, and
Hi.
thank you, Professor Zalili, for this opportunity. So I want to ask a question, maybe of us, the young neurosurgeon, maybe 2 questions. So the first is, sometimes you will feel overwhelmed and maybe you think you are not on the right path, that you're not learning enough, or your learning curve is in a plateau.
You're cutting out a little bit. Can you start over with the question?
So what do you do in those? Yes, okay. So 2 questions, which I think most of the young neurosurgeons have, is sometimes we reach a time in the training when we think we're not learning enough, or we're in a plateau. So what we should be doing these times? And how do you define the word of being a successful neurosurgeon? Like, what is it that makes someone think that he has reached this phase of thinking that is good enough to be a leader or to be a successful neurosurgeon?
I can answer the second part. I still didn't exactly catch the first question. I'm sorry, it's the cutting out.
No worries. So the first question is, sometimes we overdoubt ourselves. How do we know we're in the right or the wrong path in our learning path?
Okay. sometimes, how do we know we're on the right path? How do we know we could be going towards the wrong path? And then how do you assess your own career at the end?
Yeah.
Boy, that's a loaded question and a superb question. I talked about self and social awareness, but both of those are really important to understand. Am I on the right path? Am I fooling myself? And to keep not just listening to others who may be trying to inflate your ego or whatever, but honestly and reflectively think about yourself. I think that's incredibly important. I'm just having trouble with words here. It's important to be steady. People expect you to be steady. It's important to be strong. It's important to be transparent, though, on the other side of the coin, because you don't want to try to fool anybody. You want people to understand who you are. And so be yourself, have a goal. And if your goal is, my goals changed over the years. When I was younger, I wanted to be the president of the Congress or the American Association of Neurologic Surgeons. And I fairly early in my career recognized that I wasn't a politico, and that being a president of an organization really wasn't necessary for me. And so I took the servant leader trajectory and tried to lead people to better places. And I think that has served me and them well. Now, I'm not certain that I answered your question.
You do. Because I think it's a lifetime question. It doesn't end with a specific answer.
Yeah, maybe I take over for the next question. And Professor Benzel, most of their works are centered around spine surgery. Do you do cranial surgery or do you do just spine surgery? And if you're doing just spine surgery, at what point in your life did you decide to focus just on spine?
So interestingly, I briefly went over this in my training. I did a neurosurgery residency, and then I did a spine fellowship, and I say that in quotations because up to that point, there was not such a thing as a neurosurgery spine fellowship. And so if we call what I did with Dr. Larson a spine fellowship, then I was the first one. And so I developed a specialty, but then I moved to Louisiana. And the partner that I had there left after about a year, and I was stuck holding the bag in a busy program. I did as many as 600 cases a year with no neurosurgery residents. During that time, I did 50 ECIC bypasses in the day when ECIC bypasses were in vogue. I wrote papers on that. I did some basic science research. So I seized the moment. I used the resources that we had. It'd be impossible to do that today, at least in the United States, because there is so much emphasis on control, rules and regulations, etc. Having said that, I was able to be my own person to do these things. And so I did a lot of carotid endarterectomies and brain tumors, and I even did a lot of much complex pediatric neurosurgery. And that tapered off quite a bit when I went to New Mexico because I had a pediatric neurosurgery partner there. I had more resources, and I started focusing more on spine. And when I moved to Cleveland, Ohio, to the Cleveland Clinic in 1999, I basically quit doing cranial surgery and focused on spine. The only cranial surgery I did would be like trauma when I was on call. And so I have been able to focus as a neuro spine specialist for the last 2.5 decades, 25 years, quarter of a century.
Dear Ed, it was great talk, really. Can I ask one thing? Actually, the education is getting troubled in currently in neurosurgery and also spine surgery, and then the juniors do not get much involved in patient history and patient evaluation, and they are more interested with the techniques, surgical techniques. For instance, they try to learn more endoscopic techniques or implants and others. What do you think? What shall we do for improving our education in spine surgery in the future?
Well, there is a phrase that I like to use a lot, and that is the decision is much more important than the incision. First of all, at least in the United States, and I suspect to some degree in most parts of the globe, we do too much spine surgery. And there's got to be a lot more reflection on what is the best way to do things. And it's not always surgical. Because if we're honest with ourselves and we're operating, say, on degenerative lumbar disease, there's a lot of patients that don't have great outcomes, do not have good outcomes. And it's real easy to get sucked into the vortex of surgery because, in quotes, nothing else is working. But another favorite line of mine is, if nothing else is working, it doesn't mean that surgery will work. And so we need to be honest with ourselves. We in the United States are driven by the almighty dollar. We get paid for how much we do. We don't get paid for the good we do. And I would like to see, moving forward, a movement in that direction where good outcomes are reimbursed and bad outcomes are not. We got a long way to go there because the politics, which I already said I'm not very good at, are a formidable opponent. Did I answer your question, Mehmet?
Yes, thank you.
Dr. Naren, I think he has his hand up. You can unmute your microphone. Your microphone is muted.
Thank you, Ignatius. Dr. Benzel, thank you very much for that excellent and inspiring lecture. I just want to ask you on the question where the politics and the clinical and the economics intersect. As you said, that when you see a spine, you want to not just do a laminectomy or discectomy. You want to look at the whole patient, look at the sagittal balance and any deformity and correct it. But the usual, the way the current practice certainly in my part of the world is to just do the quick thing and do the next one, and the numbers actually count, not necessarily, as you said, how the patient does in the long term. And when you try to do something as thorough as that you say, there will be resistance. Why, when everyone else is doing this, why do you have to take, why do you have to make it complicated, long, and obviously more complicated operation does carry more complications. How do you first of all change a practice when your practice in your department or in your country is different, and then how do you manage to so that's the crucial thing. What I'm trying to ask is that a thorough approach is great, but it might not be so great in the environments that you work in. Thanks.
Yeah, that's a seminal problem associated with indications for surgery, etc. A little bit ago, we were talking about the new technologies, and boy, they're a lot of fun to work with. I mean, video games and new gizmos to fix the spine, etc. And we can become enamored with that. We can also become enamored with just operating on the X-ray or the MRI or the image, rather than taking into context the person. Now, I'm going to use an example, which I don't know how much you all have thought about, is the patient with a chronic pain syndrome. They may have some degeneration in their lumbar spine and complaining of back pain. But if that pain is there 24/7, they do not get restorative sleep because of pain bothering them at night. They wake up and stay fatigued throughout the entire day. You're not going to help them with surgery. They have a non-surgical problem. And right now, our diagnostics do not help us with that. I think with AI, we may be able to drill down on that a bit and sort out patients who are very poor candidates for surgery. And the trouble is that the patient so afflicted resists therapies and strategies which we know work, like seeing and working with a pain psychologist. And I'm sure that in other places in the world outside of the Cleveland Clinic, pain psychologists may not exist at all, or may be very difficult to get a hold of. That leaves you without a treatment for the patient. And you can play pain psychologist yourself and talk to them about the various strategies of pain and pain management. But you can't do that as a surgeon. Maybe you could hire somebody to do it in your clinic who doesn't need to do X number of operations a year in order to stay employed. But it is a significant problem. And fortunately for most of the people here, I think it's not as much of a problem as it is in the United States, although I don't know for sure. I think we've created in the United States an entitled environment, and people feel entitled to get treatments, and the treatment they want is passive treatment. So there's two different kinds of treatment: passive and active. Active treatment is for them to do exercises, lose weight, stop smoking, do the things that are known to have a positive effect. They want to have a passive treatment, though. They don't want to actively participate most often unless they're coached properly. They want to lay down on the bed with their arms out and say, "Doctor, heal me, operate on me." And you say, well, that's active. It's active on the part of the doctor, but for the patient, they don't have to do anything. They just go to sleep and hopefully wake up with improvement. And if they have a chronic pain syndrome, they're probably not going to be improved. Tell me, people tell me, is this concept foreign to you, or do you deal with this in your practices around the world?
We face similar stories.
Okay. So what do you do about it? when a patient says, I got all this, I don't sleep well, I'm fatigued all the time, I have 24/7 pain, but heal me. What do you do? I'm putting
We
it
try
back.
to talk it through, and then we send them to a psychologist or psychiatrist to help them with the pain medication. But sometimes they don't want to. They don't want to go for the active treatment. They actually want the passive treatment, and that's the whole loop.
Yeah, so we have to have our guards up, okay, and not cave into that, because we're not doing them a favor. In fact, they could be angry with us because they're worse. And so, if a word of warning, if you end up operating on a patient because maybe you can make them better, you need to make it clear, perhaps in writing, that this is a low yield, high risk operation, and the patient chooses to move forward. And to see, I don't know what medical legal consequences there are in other countries, but in the United States, there's lawyers around every corner that would just love to get into the courtroom with a surgeon.
One quick question. Professor Benzel, while I was a resident, I attended a few courses in Turkey where I met Professor Zilili. You and Professor Zilili, you share a lot of things in common. You've published books, you've published research articles. We've also met some surgeons like Professor Yasajil. He just wrote a lot of books. He said he was a bit frustrated with the rejection rate with articles. So most of his work is published in books. So what advice do you give to young neurosurgeons? Do you encourage them to publish more of research articles or books, or both?
You see, if I have a career that is desirable, it was situational. You can't likely do now what I did then. At least in the United States, there is no job in which somebody could come in right out of their residency and start doing everything. It just doesn't exist. So my advice to people is and I just, honestly, the biomechanics thing and spine surgery, when I started working on the equations, etc., I went back to the physics books and I just said to myself, regular college physics. I said, well, it's all here. They're describing spine surgery in the physics books, and they have no idea that they are. And I says, all I needed to do is translate this for surgeons. But I was lucky. I kind of had an idea, and I was able to pursue it. And I'll bet you 99 out of 100 times if I were to do it again, I wouldn't be successful. So I give a lot of credit to luck, but I also give credit to my wife, the pillar. And I also give credit to myself for persevering and sleeping so little and working so hard. Hard work. There's a rock star group, Rush. They have one of their lines is hard work is the key to good fortune. Hard work is the key to good fortune. Now, I'm going to change the subject a bit. I'm retired since January. Now, I can't imagine having gotten up at 5 o'clock every morning to go in for rounds and conferences, etc. When I still go to occasional conference now and then, and when I do, it's very painful for me. And so somebody said, I really quit operating because I got Lyme disease. And I developed a tremor and a little balance issues and some back pain. And it's not been fun, but I'm still Ed Benzel. But I really kind of had to quit surgery. And then after another year of non-operative stuff, seeing only those chronic pain patients, basically, who are not fun at all, I said, it's time to quit. And at the same time, there was much more of a demand on surgeons for generating revenue. And I said, when during the negotiation phase for my current position, which is an unpaid academician, basically, I get to keep my computer, my cell phone, my email address, access to patient medical records. When I did that, they said, well, I'm the first person who ever asked this, evidently. They said, well, why don't you take 10%, be a contract surgeon for a 10% salary? And I says, no, read my lips. I do not want to be paid anything. I do not want to have you have any control over me. I want to teach, mentor, do research on my own and on my own time. And so I was fortunate again, and was allowed to do this. I guess getting back to that line, hard work is the key to good fortune, still prevails. Nothing is given. You got to work for it.
Thank you so much for this talk. It's very inspiring. I'm not sure if you have any more questions from the participants.
I think there is not. Tarek, you want to tell something?
Thank you so much. No, I'm very, very, inspired by this really generous discussion with Dr. Benzel. I'm more of a cranial surgeon, but his wisdom, transpires and to every domain of neurosurgery. And it's been a pleasure to hear his talk and share this, session with my colleague, with you, Dr. Zalili, and Dr. Heba and Dr. Esene. Thank you so much.
You're very welcome. If I could leave a message for everybody here, particularly the young ones, has already been illustrated and said in my talk, that is lead. People sit back and assume that they're not senior enough or whatever. We are all leaders. We can lead patients to better places. And if we think of ourselves in that way, I think we become better physicians and better people.
Thank you.
Thanks a lot, Ed Benzel. I must tell that he is also my mentor, and I have enjoyed a lot working with him for many years. I think we can close the session and wish to see you in future webinars.
Okay.
Thanks a lot.
I hope this was good for you all. It was most certainly good for me.
Yeah.
Thank you. It is.
Absolutely.
Thank you. Goodbye.
Thank you.
Bye-bye.
Thank you.
Goodbye.
Uh-huh.